First panelist to be introduced is Delegate Terri Hill. She's a physician and a leader in the House of Delegates on health policy, who's been instrumental in advancing thoughtful and balanced healthcare legislation. And we thank you for being here, Dr. Hill. We're also joined by Senator Clarence Lamb. He's a physician and key leader in the Maryland Senate who brings both clinical and legislative insight into many of the issues we'll be discussing today. Thank you, Senator Lamb, being here. And last, and absolutely certainly not least, is our own CEO of MedChi, Mr. Gene Ransom III, who leads physician advocacy efforts across the state and has been deeply involved in value-based care initiatives, payment reform, and physician engagement in the total cost of care and AHEAD models. So let me set the stage. So as Maryland continues to lead in many areas of healthcare innovation, we're also facing real challenges that directly impact physicians and patients alike. I'd like to start with Mr. Ransom. If you could give us just a very brief summary to help us set that stage of what we were challenged with in this past session, what we accomplished, and what are the issues we're looking at as we move forward. Many are recurring issues, and then we'll open up the discussion and I'll pose some questions. And I have some questions that we've put together as a panel, and we'll open it up should we have time for additional questions. But let's listen to the questions. Please be patient with me and us as we go through the questions we have prepared, because they may cover many of what pops up in your minds as this panel discussion progresses. So thank you in advance for your patience. And Mr. Ransom, please take it away.
Thank you, Dr. Wargotz, and I hope everybody can hear me okay. First of all, I just want to say that we're very, very blessed and lucky to have Dr. Hill and Dr. Lamb in the General Assembly, having physicians who actually practice, and we have one who's obviously in private practice and one who is in academic practice, and one who works principally in a hospital most of the time and one who works in an office most of the time. It really lets us have somebody in the actual room where the decisions are made. They can at least explain what it is to practice medicine. They're really helpful to us, and even when we might have little disagreements with one or the other, which rarely, if ever, happens, there's still such a big benefit to MedChi, and there's such a big benefit to the profession, and we're very lucky they're there. There are really five big issues or topics that MedChi things kind of fall into bucket-wise that we were dealing with this session, and I'm just going to give a high-level overview of where we did and how we landed on each of them. And I will say that this was a particularly challenging session. There was a lot of tension, a lot of problems. Even though it ended up being a very good session, it was difficult. With regards to the budget, we were able to maintain close to parity with Medicare, which is a priority for Medicaid. That was huge. The issue there is that while in the budget we kept Medicaid rates at 99% of Medicare rates for E&M codes, there is a major budget deficit. We also managed to fund LARP as well. It will be very difficult going forward to maintain these funding levels given some of the pressures from the federal government and the looming budget deficit. The second big pot is tort reform. We were in a large war with the trial lawyers all session. They had legislation to repeal the cap on non-economic damages. They had legislation to allow punitive damages to be expanded to malpractice. They had multiple bills in that were really bad for the practice of medicine and would have raised our malpractice rates. We were successful in killing all of those. That was a big positive. Our vote counts on those issues in those committees are not good. And if we ever have a real vote where democracy breaks out in Annapolis, we could have a problem on our hands. This is something that we really need to focus on politically going forward. Public health, I think we had one of the most robust public health agendas this year. I won't go through every bill, but I'll put the complete legislative wrap up in the chat, and you can read all about all the things we were involved in. I think the highlight, though, of the public health was the VAX Act, which is something we affirmatively worked with the Moore administration on, and that essentially set standards such that we did not have to blindly follow the federal government. We actually considered the standards created by the physician specialties who manage those things. With regards to insurance reform, Dr. Hill and Dr. Lamb passed a credentialing bill through the General Assembly that'll allow credentialing to go quicker starting at the end of the year, which was a big win. And as a result of legislation around downcoding that went in, we got an order from the Insurance Commission stopping downcoding by Cigna. So the bill didn't pass, but we got an order which was actually better than the bill. And then what I would say is the most troubling issue by far, and the one we had the most difficulty with, was scope of practice. Um, we had multiple scope of practice bills. We were talking in the chat a little earlier about the psychology issue. They tried to prescribe. That bill did not move on either side. The naturopath bill that expanded their prescribing and scope passed the House and was killed, luckily, in the Senate, thanks to Senator Bidel and others. The pharmacy direct treat bill passed the House and was killed in the Senate, again, thanks to Senator Bidel. And then we had legislation in for the ENTs that would have fixed some audiology scope issues that we managed to get passed through the Senate, but died in the House. So scope was very, very challenging, and we came close to having some big losses. So I'll stop there, but Dr. Wargotz, that kind of gives you a high level
Yeah.
overview of the big issues for this session.
Thank you, Mr. Ransom. Appreciate that. So let's move forward. Let's move to the current and move forward. And we're going to come back to some of those issues Mr. Ransom discussed in a little. We'll come back to them in a little bit. But it's always nice, I think, to get the legislators' views of what our biggest healthcare challenges are, and then sort of go from there as well. So I wonder, I'd like to know, Delegate Hill, from your perspective, as we move forward 26 into 27, what are the most pressing healthcare challenges facing Maryland today, and where should we be focusing our efforts in the coming year? So, Senator Lamb, you can take note because that will be coming to you after Delegate Hill. So, Dr. Hill, what are your thoughts on where Maryland's going? What are the most pressing
All right.
healthcare issues?
So first of all, thank you for having me and for convening the panel. And I would agree with all the points that Mr. Ransom made. I would say this, I think that probably number one, two, and three would be cost, cost, and cost. Cost of healthcare, and with the federal supports for Medicaid, particularly being undercut. The cost of healthcare is going to continue to be a major issue. And on top of that, we are still dealing with the issues that most jurisdictions are seeing with respect to wait times and general accessibility to healthcare that probably don't affect most of the people on on this call, but affect too many other people when we see the cuts that are coming down, even though we were able to put some slow down maneuvers in there and backfill some of what will be taken from the big beautiful bill. We know that this is going to be an uphill battle. I also think that we need to continue to look at, and as a state, provider burnout, provider reimbursement, provider shortages.
I think we lost you there, Dr. Hill.
Yeah.
Okay. Well, thank you, Dr. Hill. We'll come back to you if you feel there's more. But Senator Lamb, how about your thoughts on, what are we facing? It sounds like a lot of the same old, same old. There are ongoing challenges, but what are your thoughts?
Yeah, I mean, thank you, Dr. Wargotz. It's glad to be here with the team from MedChi and with my colleague Delegate Hill as well. I'll try to finish her thoughts there. Agree that cost is a huge issue. We're seeing an environment where there are significant cutbacks from the federal government, which supports a lot of healthcare access and programs. The state, we have to balance our budget every year, and so. That's a constitutional requirement. We cannot print money. And so we have to figure out how to live within our means every year. You always hear about budget deficits. But the reality is that every year we balance our budget. So these are projected shortfalls that when you look at the incoming revenue with the state, you have to meet that with the expenses. That's where some of these cuts matter, right? Where if you look at Medicaid cuts, that's going to be reductions for reimbursement, that's going to be healthcare access issues for our patients. Those are really significant concerns that continue to be coming forward in looking at some of these out years. The other things I'll touch on just briefly are number one, I think it will be more difficult for our patients to access services, right? So, in addition to the budget cuts and the funding cuts, there were significant requirements that were put in place for patients for redeterminations of Medicaid that have to be done every 6 months. That there are new work requirements for individuals that qualify for Medicaid otherwise have to meet. And those are significant. Those are additional burdens that the state is going to have to jump through to be able to prove that these individuals can stay on Medicaid. There are additional burdens that patients are going to go through to be able to stay on coverage as well. And this is a population that's already been tough to be able to work with. We're going to continue to see other areas where access continues to be chipped away at. And that presents some real issues in deferred care, in people coming into your clinics and offices in our hospitals, even sicker than usual. The last thing I'll touch on is that the environment on top of that is changing very rapidly, not just at the federal level, which all of you are seeing, but also we have an election coming up at the state and local level too, where we may have many new individuals elected to the General Assembly who, for the most part, many of our colleagues don't have any familiarity with these issues except as consumers, as patients of yours. And so there's a lot of potential there for education, but there's also a lot of risk of people coming in, not really understanding our healthcare system, being put in committees or places of decision making and leadership, making decisions on policies that really impact all of you. And so there could be a lot of change coming into the General Assembly. We've seen a lot of change even just the last 6 months, 12 months with leadership changes, with new people coming in, new appointed individuals. And every time we have an election, there's, especially these days, a significant number of turnover. And so you could have, a quarter of the General Assembly as new members coming in too. And that's really where it's incumbent on all of you to be able to reach out to your legislators, build that relationship. Obviously, the two of us are always here to advocate for all of you, but it's really important for them to hear from others because we're only two people. We're always talking, the healthcare system and what's best for medicine. They get that, but I think actually what resonates a lot is for them to hear from actual physicians and individuals in their community and to bring those personal stories, the patient stories that resonate with a lot with our colleagues. So, when you look at that landscape, there are a lot of potential landmines coming up ahead. We'll obviously work with you to try to minimize those risks.
Thank you, Senator Lamb and Delegate Hill. So before we get into the meat of Medicaid, which is going to be our first question, and the challenges in Maryland, I would like to pivot on what you ended with and ask Mr. Ransom if he could explain to us the membership, the nearly 100 people on today, what we do in these situations. Now, let me put that in the context Dr. Lamb was referring to. There are many new members coming in potentially, and we're already aware of leadership changes. And I think we see these changes ongoing every year, but this year seems like it's going to be more robust. The number of changes in leadership and perhaps even in seats with new members. So, Mr. Ransom, if you could explain to all of us on today what MedChi's approach is. I know you have a structure in place on what we do to familiarize not just ourselves with the new members, but the new members and the new leadership to become familiar with us, who we are, what we do, and what we're looking for.
Yeah, so maybe it'd be helpful too to talk a little bit about how we take positions and what we do as well. So we really are a member-driven organization. So with regards to positions, the votes of this House are how we decide what we work on. with regards to communicating and dealing with the General Assembly and dealing with the changes in the General Assembly, I would say that really MedChi and its components, and I say components because all politics is local, and it's really important that we work closely with each of the county medical societies. We really try to pay attention and communicate. Most counties in the state of Maryland, most county medical societies in MedChi have key physicians lined up with every legislator and the General Assembly, and we try to make sure that we know those members before we need them for a big vote or a key vote. Now, the challenge with that is that recently, particularly, we've had such turnover, it's been very difficult to keep that up to date. So if any of you are interested in kind of being a key contact or getting close with a legislator, we'd love to have that. The other thing we do is we run the first aid room in the Capitol. So we have physicians down in the Capitol every day during the General Assembly session. You get to volunteer for a half a day. You get to be on the floor of the House or the Senate. You get to actually see people and see how things work. And then I think the last thing, and maybe one of the more important things that we do, is we have a PAC, and we do work politically to help those who help us and look for opportunities to help legislators or people who would be legislators who might be friendly to medicine. So, for example, the PAC has been carefully looking. We're very excited because Dr. Ford's son is going to be running for the state Senate in Prince George's County, for example. So we're looking for opportunities like that. We have a physician in Montgomery County whose brother is an orthopedic surgeon who's running for the House of Delegates and actually in an open seat. Both of those seats I just mentioned were open seats. So we're paying very close attention to who's running where and who might be friends of medicine. And that's another thing we do, Dr. Wargotz.
Thank you very much. And it's important to remind everybody that Delegate Hill and Senator Lamb are the only two physicians in our state legislature at present. Dan Morheim, of course, served many years, and we thank him for that. But we just have two now, and it's important that we work closely with these two at all times, whether we agree or not, and try to recruit and encourage other physicians to get involved. So let's move into some of the real meat of what we need to deal with here in Maryland, the Medicaid and the payment stability issues here in Maryland. Medicaid plays, as everyone knows, Medicaid plays an increasingly important role in our health system, but physicians continue to raise concerns about reimbursement, alignment with value-based care, and administrative complexities that are associated with participating with it or having patients involved in receiving Medicaid. So let's lead off with Delegate Hill. What new steps or additional steps can the state take to strengthen Medicaid in a way that supports both patients and physician participation and ease of care, ease of administration of the program?
So thank you. If I go out again, I'm gonna go on to a different device.
Please,
but I appreciate Senator Lamb picking up as I drop the ball. So Medicaid, as you all know, we have a projected $2.7 billion loss coming down from HB number 1 for 2025. What we tried to do this session is backfill it a little bit. We invested about $13 million specifically to manage eligibility and minimize unnecessary disenrollment. Senator Lamb spoke about, the fact that we're also seeing, efforts to make it harder and harder for people to qualify, which is always interesting to me because it's presented as if, Medicaid is a payment to the recipients as opposed to the payment to the providers who provide the care. Right. But we're going to put them through work requirements to make sure their providers can be paid. So we're going to have to do something with that. And I think the bill that I'm most excited about that we passed was a reimagining healthcare. It's some work that now Speaker Jocelyn Pena-Melnick directed, Vice Chair Bonnie Cullison, current Health Chair Heather Bagnall, the Subcommittee on Appropriations on Health Chair Emily Shetty, Delegate Sheila Ruth and myself to work on during the last interim, and it's passed in the legislation. This is a work group. We're not going to be on it, but this is the work group that we think is going to help Maryland look at how we have to do things differently. How do we deal with a federal administration that is less and less reliable? And are we too tied to old models of healthcare delivery that no longer work? And I'm not talking about a head model or the total cost of care model. I'm talking about sort of looking at the entire piece of how we deliver healthcare. So I think that's going to be a big part of how we move forward, because I think everyone on this call would probably agree to some extent that what we're doing now, not just as Maryland, but around the country, just isn't working. And if we keep doubling down, trying to get something that's broken to work, as opposed to coming up with something different, we're not going to do ourselves any favor. So I
Okay.
think
Well,
that's a
thank
big
you.
piece.
Well, thank you. Well, Senator Lamb, I want to try to avoid repetition, but everyone, certainly should share their opinion. But I'd really like to focus on, well, how do we deal with these? So we identify the issues. We know what many of the issues are. How are we going to tackle these? How do we come up with a sort of a different paradigm for administration of Medicaid in Maryland? It's been a problem for many, many years, as we all are aware, not just the payment for physicians, although that's important to us, of course, but our charge is the public health and caring for patients. And it's really frustrating not just to be underpaid, but to see patients underserved. And so what are some of the thoughts of that we can do? How do we do better, Senator Lamb?
Well, I think the reality is that there will be fewer people served. I mean, there's only so much that we can do, as Delegate Hill points out, that to help reverse some of the trends that we're seeing here, simply because we can't print money, and we are at a bit of the mercy of the federal government, who provides the funding while we do the administration of these Medicaid programs. The Medicaid program, the funds come from the federal government, and the stipulations and the strings that come with those funds are additional requirements that the state has to meet. I think the state is trying to be smarter about how we can go about doing so, right? So Delegate Hill mentioned that there was additional funding that was put into the state's budget. This was kind of an initial investment to figure out how we can get our systems to talk to each other better behind the scenes, to reduce the burden of some of these redeterminations on patients. So, an example is we have various state databases and systems that might collect information about whether an individual is working or not, and to what degree. Can we get those systems behind the scenes? For example, tax records or payment uh, tax records, to be able to talk behind the scenes to our Medicaid system, so that it doesn't place that additional burden on the patient to have to, or the beneficiary to have to provide documentation showing that they can continue their Medicaid coverage, right? And
Well,
so,
that's important, Senator Lamb, if I might interject. Are you able to do, or in Delegate Hill, can give us sort of a recap on the implementation of that work requirement? What the timeline is, because I don't recall
Every
offhand.
6 months, you have
Uh,
to recertify every 6 months.
okay,
And that
and that's
starts,
already begun?
no, it starts later
Okay.
this year.
Yeah, I think that's what
Right,
someone was
yeah.
asking.
I,
For
I'm
some reason,
thinking
all of the
January
difficult.
2027. I'm sorry,
Okay.
Gene,
No,
you just
Uh,
muted yourself.
Go ahead,
no, I'm
Delegate
just
Hill.
saying, go ahead.
Around January 27th, is that what you were saying?
That's I may be wrong about, but I think that's correct.
Okay, I'm
Right.
sorry. Back to you, Senator
But
Lamb. I just
yeah,
wanted to get that out there.
yeah, I
Everyone
mean,
with
I
us?
think I think the state is trying to be smart. So, like, what you saw with that was the initial investment to try to address some of those issues. I think we're going to have to look at other ways as well. I think there's also an effort afoot to look at other states that, with take-home messages that we can bring back here, with best practices that we can look at. There have been states that have had work requirements in place. And, we believe that there are some processes that they've already worked through and streamlined. So rather than recreating the wheel again, is there something that we can take away from these other locations? I think this process that you saw, and there's a couple $1 million that's been put into this at the state level in our budget to be able to better connect the interoperability and the communication between these systems is really just a start. I don't think these requirements are going away in the near term, and so we're going to have to figure out and design systems that can better talk to each other, that can share this information, to work as seamlessly as possible. None of this is actually easy in the background because, as all of you know, a lot of these systems that we're working within are either legacy systems or never designed to talk to each other. And so this will take some time. But to Dr. Wargotz's earlier point and question, I think unfortunately fewer people will have care. That's just the reality of
Well,
what we're facing. That means that people will come in sicker. There will probably be more people coming into our EDs because they're using that as our front door for primary care. That will mean that, I think there will be additional individuals that might see our specialists delayed because they're not able to,
right.
they're holding off on the care that they may need. So, it's going to impact, I think, the entire system. We're going to have to absorb it, but it's not going
Okay.
to be easy.
Dr.
Well,
Wargotz, let me, if I may, I just
yes.
wanted to add one thing that was inherent in your question, which is you said, you talked about physicians and other providers obviously wanting to get paid, but we also want to make sure patients get good quality care. And so I think in addition to all the things that Senator Lamb talked about at the end of that long line, if patients are sicker, and our focus or the focus on how do we incentivize physicians to do a better job has been about carrots and sticks, mostly around financial reimbursement. um, I, I think there's another storm coming, because I think
Right.
physicians are
Yeah.
primarily motivated by knowing that the work they do has value for their patients, and the system that we're under is set up to always put the money out in front, and to
Sure.
think that if we don't put the right incentives, we're not going to get the right care. And I don't think that approach is helpful in the long run, and I think it's going to prove even more problematic under the circumstances we're moving into.
Well, it certainly is a very complex issue in Maryland, continues to become more complex. And I know you both know, and I'm not trying to be smart about this, but MedChi is here. We of course take positions. We make ourselves heard in Annapolis, but we also have quite a number of practicing physicians with a great interest in Maryland Medicaid, a lot of experience. Maryland Medicaid. We have Dr. Moran, we have Dr. Half, we have so many. Sorry if I didn't mention somebody else who I should have, but we have a lot of talent, a lot of interest in this subject. And I think that there is more collaborative work that MedChi as a society can do, rather unbiasedly, meaning not just on behalf of our association, our members, but our members care about the patients as well. We care about our pocket, but we're in this realm of healthcare, being physicians, because we do care about people. And so it call on us. We're happy to provide a task force who work with you all, but we need to deal with this. Medicaid is one of our biggest crises in healthcare in Maryland. So let's move on. There's a lot of great questions in the chat.
Can I make 2 quick points, Dr. Wargotz?
I'm sorry, Mr. Ransom.
That's all right.
Please.
No. One thing is that one of the changes Dr. Hill mentioned, it's really important for physicians to understand. Medicaid patients are now going to have to automatically re-enroll starting next summer every 6 months. So that means you might have a patient who's in your office who needs to re-enroll, and it could cause you problems. The other thing the bill does is it limits retroactive payments. So if you sign somebody up for Medicaid, you can go back for a certain amount of time. That time frame gets shorter. So it's going to be important that you talk to your billing people, or if you're in a hospital, your social workers or the other folks, to make sure they understand those changes and are ready to help patients sign up. The second thing I wanted to quickly bring up, we have another looming problem in 28 that no one has mentioned about Medicaid, and that is that we balance our Medicaid budget with something called the assessment through the waiver or the AHEAD program. It's about 750 million to $1 billion right now. It's called the Medicaid assessment. There's a lack of clarity as to how the Trump administration is going to deal with that. So we could have another Medicaid payment cliff that we haven't even mentioned separate from the HR1. So I just want to throw those two things into the mix as well.
Thank you. And we could do a whole hour, 2 hour, 3 hours on Medicaid in Maryland. Sorry we can't get to everyone's questions in the chat, but hopefully a number of them have been answered through the discussion. Let's jump ahead because one of the big, they're all important topics, but one that really is at the heart of our practice, our livelihoods, and our care of patients is scope of practice. I really want to make sure we have time to deal with that. So as you all know, scope of practice continues to be a major issue in Annapolis each year. How do we approach balancing access to care with maintaining, high standards of training and patients' safety, and what principles should guide these decisions moving forward? And one of the biggest frustrations we saw in this session, and we're not going to embarrass legislators by mentioning names, but a number of our members met with legislators along with Mr. Ransom, and it became quite apparent they don't understand the difference between a psychiatrist and a psychologist or various other specialties, and it's a real problem. And we're not making fun of them. It's just the level of knowledge and understanding of many of your colleagues don't have about healthcare and the physician's important role as the healthcare leader, the center of the healthcare team, is very disturbing. And seems to be never enough time to prep them on it. And it's a real problem as we try to advocate for our patients and ourselves. So I'd like to lead off with Senator Lamb on that one.
Yeah, so we saw a bunch of scope issues come up, some which we're still trying to address. As Dr. Wargotz mentioned, there's the psychologist prescribing bill. There was a huge naturopathic doctors bill that came through that would allow them to also prescribe and discontinue medications. There was a bill that we were trying to address to fix an issue that the audiologists had encroached on when it pertained to ENTs that was passed a couple years ago. That really was a bad bill. And even despite, 2 or 3 years of efforts to try to include clarifying language that even the governor had requested that be done in the statute, we still couldn't get that past the session. We saw things between anesthesiologists, nurse anesthetists, and anesthesia assistants, right? So, I think we're going to continue to see more and more of these types of scope issues come up. We actually had a good clarifying win with the physician's assistants, so that was a good one where we were able to kind of address that and fix that. But I think given the environment, I think there are going to be other provider groups and specialties that are going to come forward and ask for additional authorities that will encroach on our scope. And I think that's certainly concerning. I think the education piece that Dr. Wargotz mentioned a second ago is really, really important, right? And so we are only 2 legislators out of 188 delegates and senators. There are only 2 of us that can really try to work within the inside to advocate for our colleagues. That is a very difficult task. On top of that, as we mentioned at the top, there are probably a bunch of new legislators that'll be coming in. Some of them assigned to the Health Committee, where Delegate Hill is on the House side. Some of them assigned here in the Senate Finance Committee, where I'm at, that have no understanding of the healthcare system at all, and not even any prior experience having worked on any of these policies, even been on the appropriate committees. And so, to all of you, I think there's a real opportunity to build a relationship and to talk to folks. As soon as it's clear that they're going to be taking office, there are folks that are already in office that in all likelihood will continue to serve on these important committees, that this education needs to take place now, to build that relationship, to bring those stories of why these policies are so important, why the education that a physician receives, both in medical school and in residency, is really important. I think a lot of our colleagues don't even understand residency, right? And so, they don't differentiate why that additional level of training is that critical. They just see that, oh, someone who's a psychologist is called a doctor too, that they should be able to prescribe. Someone who's a naturopathic doctor has doctor in their title, they should be able to prescribe. And there's some real safety issues. I think here's an example of something just from a couple of years ago that was a scope issue. There was a podiatrist bill where they wanted to be called podiatric physicians that passed the House. It came over here to the Senate. At the time, it went to the Education, Health, and Environmental Affairs Committee, where I served on. And this bill is in all likelihood really going to fly through the Senate as well. And it was one senator, it was Senator, and I was trying on the inside to fight this bill and push it back and try to kill it in committee so it wouldn't move forward. But it was Senator Mary Washington from Baltimore who presented this story to the committee when we were voting, where she talked about her mother who had diabetes and was seeing a podiatrist. And the podiatrist said, well, look, the only options that we have left here is to amputate. And obviously that didn't sit well with Senator Washington. And so she had her mother go speak to a vascular surgeon or an orthopedist and basically said, look, there's some other options here. We can save your leg. And it was that story where Senator Washington shared that with my colleagues. They're like, whoa, whoa, whoa. Like, what are we doing here? Is this moving too quickly, too far? And the committee stepped back. And it was really that kind of human element that pulled that back from allowing podiatrists to be able to use the title podiatric physicians.
That's a very good
that's a
point,
great example, but this is where, you have to be able to build those relationships and be able to convey those stories to our colleagues about why that's so important.
No, I appreciate that, Senator Landy. I think it's important what you're saying is that when we testify, facts are important, but you have such limited time. If you have a story you find in politics and the political arena and legislative venues that, the statistics are important. You can send those in and email them. But if you've got a story, it often moves people. The relatable information often has a greater impact than the facts.
I would also
Believe it or
say
not.
that our
Yes, I was going to move on to you,
Yeah.
Delegate Hill,
Well,
please.
I mean, that's an excellent example, and I will tell you, that bill alone, the fact that it got out of the House, was really problematic. It put me, my efforts to fight that bill put me in the doghouse for a couple of years. But it was something, it felt really strongly about. And as Senator Lamb said, he was working really hard to stop it in the Senate, but it took Mary Washington's story. So it's not just when we testify, but we don't often bring the patients to tell the stories. We act like we're the only experts about the impact. The other thing that happens is in the interim, the committees do field trips. And, if there is a situation that is amenable to a field trip, the dentists were able to really get us to understand some of their situations and solve some of their problems, and followed up with the field trips, behavioral health. I think that we ought to be a little bit more creative of thinking about how we educate the legislators during the interim, not just during bill hearings.
Right. So we need to move on to another topic, unfortunately, given the time, but this is fascinating. And again, it deserves more attention. But I would like Mr. Ransom to just, discuss where you think, because you've always got your eyes on, you're our radar. And you seem to, you deal with all the different parties, of course, our membership who you represent, but you network a lot in the legislature and behind the scenes with private organizations and public organizations. And so what is your insight about what's coming next? We're going to get the audiology people back, the pharmacists back, the nutrition people, not the nutrition, the naturopaths back. What else? What else we got coming? What do you foresee? And then we'll move on to another
I think we have a
topic.
big problem right
We're having
now.
trouble hearing you, sir.
I said, I think we have a big problem right now with regards to scope. And the
Eh,
problem is that
you're
the,
still quite muffled.
I think we're having a big, I
Oh,
think we're having a big problem with regards to scope. Can you hear me okay now?
yes.
Okay, I think we have a big problem with regards to scope. The first is that on the liberal side, on the left side, there are a lot of people who really want to see access to care expanded, and they see the non-physician as an opportunity to do that. And on the right side, if you look at the MAHA goals, the RF Kennedy MAHA goals specifically list expanding scope of practice as a Trump priority because they see it as anti-competition. So we have pressure from both the left and the right. And then I also think that those two political things combined with the fact that science is not treated as seriously or considered like it used to be is putting incredible pressure on us from these scope positions. So I think those are big issues. I really believe our biggest opportunity to make a difference this year is the elections, and I think we need to focus on 3 or 4 elections, or the General Assembly and the State Senate. And this is something that I've definitely going to be talking with Dr. Rockhauer and Dr. Hexter at the PAC about, where we can go and try to elect people who are going to be more friendly on these issues, because and understand that they matter to patients, and that's where I think we can make the biggest impact. I think Dr. Hill's suggestion about maybe doing field trips once we know who the new people are, because it is an election year, maybe doing some field trips, and no one's going to want to do field trips in an election year, but I think that's a really good suggestion for right after we get the new members of the General Assembly, and new people are always very excited about going and meeting folks. So I think that's a good idea too. But this is not going away. It's only going to get worse, and we're going to have to fight. And I think the other thing we're going to have to do is that we get involved in a lot of stuff at MedChi. Maybe we need to focus on Medicaid and scope and tort, and focus on the big 3 things that our members care the most about.
Yeah, I think that's all.
Dr. Wargotz,
Yeah.
I'm sorry. I know you're trying to run on the schedule, but Dr. Murphy asked about, have we opposed all expansion scope bills? And Jean responded that we do support some. And I think it's important that everyone know that it's not no for no sake. It's no when it's problematic. It's no when people don't seem to understand where education makes a difference. But I wanted to get that on the
Yeah.
record. It's not just no.
No,
It's
I appreciate. Thank you very much, Delegate Hill. And I think uh, all our members do realize that we vet all this legislation that comes forward in our legislative council, and we take positions or no position, or deferred or watch type of position on all of this stuff. And we also are not an automatic no. We work with other groups, other allied health providers, to see where it makes some sense. So anyway, let's move on. That's great. So Mr. Ransom, if you could continue, give an overview. Again, we've got 15 minutes left on this program. Let's try to cover at least 2 more topics. We've got tort reform and liability, which is always a big elephant in the room, and there's a lot we could talk about, but we're going to try to keep it to 5 or 10 minutes among the 3 of you. So Maryland's medical liability environment remains a significant concern for physicians, and believe it or not, patients, and of course attorneys as well, particularly as the costs rise and practice pressures increase. So how do you all view, and we'll start with Mr. Ransom as our CEO overview, how do you view the current state of tort law in Maryland? And where are the opportunities for meaningful reform that protects patients while ensuring a stable practice environment, which essentially means also protecting, giving us a little relief from frivolous lawsuits? So go ahead, take it away, Mr. Ransom.
I'm going to keep it really short here. This is a really important issue for MedChi, obviously. And actually, this is something where we've been very, very successful. And I don't know that we get credit for the success that we've had. There are 21 states in the nation that do not have a cap on non-economic damages. Maryland has a cap on non-economic damages. Maryland is one of 3 states with contributory negligence protection. That means that a non-compliant patient has to overcome that hurdle. Maryland has a very strong certificate of merit statute. Other states don't don't have that. Several years ago, with the help of Delegate Hill and Senator Lamb, we protected our expert witness laws. There was a very nasty fight on the floor of the House, actually. It was killed the last night of session right before the prior election. And more recently, we've had incredible attacks on the cap on non-economic damages in the General Assembly, and Senator Lamb articulately spoke on the Senate floor and voted against it on the Senate floor a couple of years ago. These attacks on the malpractice tort reform structures that we have been real. For as bad as it is in Maryland, it could be a lot worse compared to other states with regards to malpractice. And this is one of the things that we just have to continue to focus on as we see more and more pressure across the country on these tort issues. The past president of the Trial Lawyers Association went crazy on social media the day after session because he said the trial lawyers didn't get anything this year from the General Assembly. So that kind of tells you everything I think you need to know about how good a job we've done on these tort issues.
Yes, and so thank you, Mr. Ransom. Delegate Hill, your thoughts. Let's. It's such a broad topic and so little time, but I think we obviously can accomplish a lot here. And so, in terms of being informative, so I'd like you and Senator Lamb but you first, Delegate Hill, to focus on the cap, the challenge with the cap. Every year it's coming back, maybe not directly at medical, but roundabout in the other sectors that experience tort liability. So, and they've lost twice, 2 years in a row. So where do you see this going? Obviously coming back, and how do we best defend ourselves? And how do you and Senator Lamb work with us, MedChi, and other interested parties to keep things status quo or even improve our environment?
Well, I think first of all, all credit to Gene and his crew. These are not issues that generally come through my committee on the House side, and I know Mr. Ransom wrote a great piece, I think, in the Business Journal a month or so ago, talking about how it was important for MedChi to even look at non-malpractice related reforms because they eventually will affect tort reform on the malpractice side. So I think he's basically summarized where we are. And I think as long as patients still find us to be good actors, if patients continue to like their physicians and want to have access to good medical care, then we will be able to continue to have a system that supports fairness in dealing with malpractice. When we cross that line and we become what insurance companies have become in the eyes of many consumers of healthcare, when we become the big farm folks, and when we lose that goodwill, it becomes very different. So we have an obligation to continue to practice medicine in an ethical, responsible fashion. And if we continue to do that, I think MedChi will be able to continue to push back on efforts to raise the cap.
Thank you very much. Senator Lamb, a little nuanced variation on that. Let me ask you this. So it is a constant threat. We love to get that monkey off our back, so to speak, in terms of, this constant threat of changes to our tort rules, tort laws, and it's not going to go away. We know that. What can MedChi continue to do with the Senate and the legislature to try to thwart this? Just keep doing what we're doing. It takes tremendous resource playing defense. We always talk about, all the resource, all the money that goes into defending our position in this arena. And we'd like to be able to dedicate some of those resources to other things because they're not unlimited. And we'd also like to be, if I could say, continue to be proactive on this issue, but it seems like we're always playing defense, and we'd like to be able to work with the legislature more closely, and even our trial attorney colleagues or opponents, so to speak, on this issue to try try to reach a point where we can just all move forward and not continue with these threats.
That would be great. I think it's going to be very difficult to get in
Right,
that place.
sure.
I think, the legislative process is always a process that's fraught with tension, right? There are always competing interests, and that's just the reality of the process that we have. That's why we have a legislature where there's always this constant give and take. People have their certain perspectives, and stakeholders have their interests, and they're always trying to drive forward with them. I don't think we're ever going to see the trial lawyers kind of back off, and that means that we're either going to be playing defense, or perhaps our best defense is a continued offense. I think, as has been referenced a few times, we do have new members coming in, and while a lot of our focus oftentimes is on these health committees, the health committee on the House side and the Senate Finance Committee here, that these bills go through different committees, right? And it requires MedChi to have to work on different members on different committees, oftentimes that have no connection to healthcare, that have no familiarity or very little familiarity with the actual health parts of the policy, who are dealing with these tort reform bills and liability issues. So, to the earlier point that there's a lot of education that needs to take place, certainly even with these other committees, which I know is just additional resources and support that's needed. This is another plug for MPAC and why that can be so important for MedChi to be able to have the resources to find and support good candidates to go into these positions and to run for office and get elected, because it's not just these health committees, it's these other ones as well that need the attention and awareness of how these issues impact all of you. And yes, the trial lawyers are very strong down in Annapolis. And I think the reality of the political environment that we're seeing is that a lot of them do contribute to campaigns, and oftentimes might contribute a lot to Democratic campaigns and this is a democratically controlled legislature. And so when they complain that they're not getting anything out of it, that does resonate with some folks in leadership and others that are in positions of power in high places within the legislature, and that's very risky for us. And so we're constantly having to push back on that. I think Gene also had a comment there that AI is the next scope battle, where I think that is correct, where you put together two issues that legislators don't understand well: AI and the healthcare system, right? And medicine. And that is particularly fraught when you have potentially the perfect storm of policies that our colleagues don't have a lot of familiarity with, don't understand. And there are certainly competing interests that are pushing forward to try to advance, these types of scope issues. So, we have an
Thank
environment
you.
moving forward that's really got a lot of issues ahead.
Well, thank you. And I'm glad you mentioned AI, because we're going to spend just a remaining few minutes talking about that. And just to remind the membership who maybe not everyone's been able to keep up with all that's been going on and what we do at MedChi. We've had an ongoing series of programs that have started since Dr. Radising, my predecessor, was president, and she continues to this day. We presented a number of webinars and programs which are available on the web at MedChi, our YouTube station, which you can watch to catch up what MedChi's been doing in health, AI health in healthcare, and what we've had to offer in terms of educating our membership and the public. But with that said, you provided that segue, Senator Lamb, to AI, and where AI in our legislature is moving forward. The discussions about that. Tell us. I'm going to leave. We're going to end this session in about 5 minutes with Delegate Hill, but we're going to start off with Senator Lamb on where we are with AI discussions and legislation impact in the legislature. So you got about
I
2
think we're
minutes.
going to continue to see
Senator.
more bill. I know we're short on time here, but I know we're going to continue to see more bills in this space. I know particularly the payers are going to look at how they can use AI to reduce, access, and we're gonna have to be vigilant on that. I had a bill on, actually, we both had a bill on down coding that we were working together on, that the Maryland Insurance Administration put out a consent order to payers to pull back and put restrictions on down coding for folks, which I know is an issue to a lot of our physician colleagues here. But it's things like that where these payers and other groups are going to be looking at using AI to try to chip away at whether it's reimbursement, access issues, and it plays additional administrative burden or hoops that you all have to jump through that we have to be vigilant about. I know Delegate Hill, I think
Thank
last
you.
year or two, had a bill on AI that helped start the discussion on putting some restrictions in place. We're going to have to continue to move along that path.
Thank
to
you,
push
Senator
back.
Lamb. Thank you. Delegate Hill, you have a couple of minutes, and I need to finish up with Mr. Ransom on
I
the
mean,
on
really nothing to add. It's both, how do we welcome and embrace the increased efficiencies with AI and push back on the exploitative, dangerous aspects of it? How do we protect privacy if such a thing even exists anymore? And how, it's a powerful tool. And we have to be, as legislators, just really mindful of how it's being allowed to work both within state systems and also if we have the proper guardrails in place in an area like healthcare is particularly important. And of course, patients are turning into it for diagnosis and treatment.
Sure.
And that has some issues. I think specifically, we've got at on one hand, looking at behavioral health and using AI. I think we had a bill that said
No, thank you. Appreciate that.
yeah, that
Yeah,
said you can't use it. You can use it, but you can't use it as if it's the psychiatrist, as if it's the treating, and trying to get what those lines are. And at the same time, there are many businesses that are pushing more AI tools that will act like the person, and we don't want
sure.
people to be confused about
Yeah.
human interactions versus automated interactions.
Very good point. And thank you very much, both of you. Mr. Ransom, the liability issue comes up as AI becomes more and more utilized in the clinical setting. Where's the liability gonna fall? And are physicians going to be required if you don't use AI and it becomes, let's say you're told you have to use it for X, Y, and Z, and then it turns out to be, the whole liability quagmire. I know we can't get into it very deeply or extensively here, but is the standard of care? Here's the question: do we foresee the standard of care maybe shifting to on the shoulders of AI, or it's always going to be us, even if we're told to use certain tools and they turn out to be wrong?
Well, the way that the legal community works and the way that the law typically works is the standard of care evolves as time goes on. And if the standard of care means integrating AI into your practice in some way, that is going to be the case. And that's why it's very important for us to continue to protect the physician-patient relationship and make sure that there's a physician in the relationship. Elon Musk
Thank you.
came out a few days ago and said that you shouldn't go to medical school because in 3 years, AI is going to be able to be as good as any old orthopedic surgeon. I think that just shows the level of lack of understanding of the art and science of the practice of medicine and the importance of human touch. And
Thank
I
you very
think,
much, Mr.
okay.
Ransom. We're going to have to wrap it up. I just want to thank you to all our panelists for your leadership and for engaging in this incredible discussion this morning. I hope all of you listening, tuning in, and seeing what's going on also felt it was worthwhile. These conversations are critical to ensuring that physician voices are part of the policymaking process. And I just want to thank all of you for being here and for the work you do every day on behalf of your patients. And thank you for joining me, Eric Wargotz, President of MedChi. I appreciate your time and your energy this morning. We'll move to the House of Delegates shortly. Thank you all.